Thank you, David, for introducing me, and this is a great turnout, and I'm really pleased to see so many people here, and also some ladies, because I will talk about a few ladies' things today. I work at Royal Prince Alfred Hospital, and I run a clinic there for people with bowel dysfunction. And I work with 6 doctors over there who are colorectal surgeons who do testing for people with bowel dysfunction. So what I'm going to cover is really all the things that with bowel dysfunction and the current trends and treatments for different types of bowel dysfunction. So I'm going to start up with, these are all the things that I'm going to be covering: constipation, fecal incontinence, obstructive defecation, and I'm going to talk about rectoceles, hemorrhoids, pruritus ani, and anal fissures. So constipation. So what actually is constipation? And we know that constipation means different things to different people. So it can be the feeling that their stools are too hard, that their bowels do not open regularly, and we know that 1 in 8 people suffer from constipation. So it's quite a common thing. There's many causes of constipation. For example, hypothyroidism, hyperparathyroidism, colorectal cancer, and there's a lot of anatomical problems. Rectoceles, common. Hirschsprung disease, that's very rare. Megacolon, rare. Nerve disease, Parkinson's or diabetes. Injury. And there can be functional problems too. Our medications can give us constipation, particularly opiates, antidepressants, diuretics, peritoneal dialysis, pregnancy and after childbirth, following an operation, eating disorders, diet, so your fibre and fluid intake, lifestyle and bowel habits, stool impaction in the elderly, sexual abuse in women and men, psychological disturbances, fear of pain. It does go on and on and on. So there's many factors that contribute to the cause of constipation. And so what is actually normal? And we know that discussing our bowel function is the most personal and private topic. Therefore, people don't know what is normal. I mean, just can you imagine if you went to probably not this group, but you went to another group of friends and you wanted to start telling them about, your toileting habits. They might say, listen, a bit too much information. People don't really want to discuss it. So, and that obviously, bowel and bowel function is my favourite subject, so I love talking at these forums. So when I got the email, would you like to come? I think I sent it back immediately, yes, I'd love to come. So what, sorry?
You do love it.
Yeah, I do love it. So what is actually normal? So normal is not too hard and not too soft. Easy to start, easy to do, easy to finish. No pain, no bleeding, no straining or forcing. I have to put the word forcing because I see a lot of people that say they never strain, but what they do is they force. So you see, straining's a bad word, but if I say, do you force? Oh, yes. So you do need to push with your anal muscle. When completed, you feel empty. And then you feel happy, satisfied, relieved. And it's actually a good feeling, very satisfying feeling if you've passed a good motion. And all of this, and it's true, isn't it? Yeah, all of this should only take 1 minute.
They're not motions of feedings, are they?
No. These are poo motions. So the frequency. So this actually varies widely. So it's normal for someone to go 3 times a day, and it's normal for another person to go 1 time a day, or can go once every 3 days, and anything in between is normal. So it's quite a variety. It's quite normal to miss a day or a couple of days. And also too, men's bowel function tends to be a bit different than women's bowel function. Because women's bowel function, sort of hormone disturbances or hormone drops or, menstruation, that can impact on women's bowel function. I see a lot of women in my clinic, and I have to tell them not to listen to their husband, because a third of men go to the toilet every day, like clockwork, after breakfast. And, those third of men discuss it because they think that that's quite normal and they're proud of it, but it's really not the case. So it can be 3 times a day, it can be once every 3 days, and anything in between, that is normal. So I've got here the Bristol Stool Form Scale, and type 3 and type 4 are normal. And I have a number of them over on the desk there. There's actually a lot of things on this desk for you all to grab. I mean, just so you can read it lately, read it and reference it. But actually, this is a very good tool. I've been running that clinic that I work in for 19 years, and I got this one about 15 years ago. It's really good just to show people, because before this picture, which came out of Bristol in the UK, there was nothing like this. And this makes it easy. You can just point. So, and laugh. And that's what people do, point and laugh. Okay, so what should we do to have normal bowel function? And of course, the 4 Fs, the golden rules of good bowel function. Yeah. The good F word. I want you to think about what the 4 Fs are. I think some of you know because you've heard me speak before, and there's a few people in here that I do recognise. So, of course, fibre, and I heard that over there, fibre. So we need a balanced fibre diet of about 30 grams per day. And, this is all fibre, fruit, vegetables, cereals, grains, all of the fibre foods. And this is a little quick rundown of what constitutes 30 grams of fibre. It's quite a lot of food, actually. The World Health Organisation say about 25 to 30 grams of fibre. So why do we need fibre, though? We need fibre to maintain digestive health, to stay regular, and to feel full at meal times and in between meals. So, but what does fibre do? What it does, it normalises the transit through the bowel, through the colon, right? So normal travel time. It absorbs water and it increases the bulk in the stool, in the poo, and makes the stool softer. So, but why do we need balanced fibre? Because the balance is really important. Because too much fibre would give us loose stools, and that is it gives fast transit through our bowel. Now, just say if everyone here today had 2 kilos of grapes each. Now, you would imagine that tomorrow you're going to have a really runny poo because you've had a big influx of fibre. And what the fibre does, helps the travel time through your bowel. And if you don't have enough fibre, you get hard stools because it's travelling too slow through the bowel. The next F is fluids. We need to drink 6 to 8 fluid drinks per day. We know that water is the best, but they don't have to be water drinks. I see a lot of people in our clinic that won't drink water, don't like water. And, believe it or not, there are a lot of people around that don't like water. But there are other options other than water. And these are the options. It can be, of course, your tap water and bottled water, but it can be juice, milk, cordial, soups, mineral water, tonic water, soda water, herbal teas, decaf tea and decaf coffee. I've got someone shaking their head there. He probably loves water. Oh, no. You shouldn't have probably, look, it's all right to have some. It's all right to have some, but if people have a bladder, and this is what I say to my patients, and I'm only a bowel nurse, I get a lot of patients that drink lots of caffeinated drinks, and they have a problem with their bladder. So I really tell them, look, if you've got an irritable bladder, or you go to the toilet a lot, or you get up a lot at night, ease off the caffeine, ease right off the caffeine. It really does make a difference. So I talked about these caffeinated drinks as not an option, because drinks with the caffeine, all of these drinks I talked about, and caffeinated drinks, tea, coffee, cola drinks, and the drinks that the younger people drink for energy, the V drinks, the Bull drinks, the Mother drinks, they're very high in caffeine. So what happens is you drink those, and they're what they call diuretics. You wee them out, you excrete them out. So basically they never get to the bowel. So it's the same as alcohol drinks, one beer, you've opened the lid and off you go to the toilet, you're going to the toilet because it's a diuretic. And the same with good chocolate, that contains caffeine as well. But I wouldn't ask you to stop that. No. Okay, so decaf tea and coffee are better hot option drinks. I talk to a lot of groups of aged care facilities, nursing homes. I talk to the staff and the managers of those facilities, and talking about, the elderly people. I'm talking about the people much older than all of us. Those people, they love their cups of tea, in the aged care facilities. And so, we're getting a lot of facilities to change to decaffeinated tea, because they can have 6 to 8 of those a day, and they don't have to have any water. So it is a much better option, if you can change to decaf. So why do we actually need fluids? To stay healthy, to be well hydrated, and of course it's vital for our survival. So the third F is fitness. So if you don't move, it won't move. And that's true. People with the worst bowel function are people that are, say, bedbound. And people with the best bowel function are our athletes. So why is exercise good? It's maintaining good bowel function. People that don't move, obviously, they have the worst bowel function. Look, in all exercise, it's good. You don't have to go to a gym or do any of that. It's just walking. It's doing the gardening, moving around. Don't just sit all day. So any exercise. Of course, walking is the easiest. Just keep your body moving. Now, the next one is about the feet. And this is last of the 4 Fs. So I'll tell you a story, though, about the feet, and I'm sure you'll all know what I'm talking about. Our bodies were never designed by whoever designed our bodies, the engineer, to sit on Western toilets. It's true. The Western toilets have only been around a few years. We were actually designed to squat. So you think of all the people that squat all over the world. The squat toilets. They're very hard to manage, but what it does change things for us. It changes our insides. And of course, these are some of the squat toilets. Now, I'll talk about this, why squatting is better, and to show you the design reason. Here's a picture of our rectum while we're sitting or standing, and our anal canal here. So what we've got here, this muscle here, is called the puborectalis muscle, right? It's attached to the pubic bone at the front. The bone at the front? And it goes round the back of the bottom of the rectum, and it gives us this angle, the anorectal angle. It's to help with our continence. So we have the muscles in our anal canal to help with our continence, and we have the angle, the anorectal angle. So, but when we squat down, the anorectal angle relaxes and it straightens. See, straightens out the angle. So, that very clever person that designed our bodies, we were supposed to do that. We were supposed to squat. And really, there is more people all over the world that squat than use Western toilets. Don't get frightened, everyone. I'm not going to ask you to squat. But there is an alternative. There is an alternative. Benefits of squatting: it helps prevent people straining and it makes evacuation faster, easier and more complete. Of course, because it's just the nice, clean, wide exit. I'll just go back to this actually. This is an interesting, I'll tell you about the toothpaste story. Okay? Say you have 2 tubes of toothpaste. Say this is the first tube and this is the second tube. Now in this tube of toothpaste, it's just got a little pinprick exit. And in this tube of toothpaste, it's got a really big exit. We've all seen them, haven't we? Right? So if you try and squeeze the toothpaste out of each of these toothpaste tubes, this one with the thin exit, you're going to get really narrow, skinny. This one, you're going to get a nice, big, floating, if it was Uranus, big poo. So, you know, a lot of people ask me, oh, you know, my poo's really skinny, or my poo's it's like a log. And I say, yeah, you're supposed to have a log, you know, a log. Just a little bit of information for you that you're not going to talk over coffee. Talk about. Okay, so we're talking about the benefits of squatting. It helps both children and adults develop good habits of evacuation. It reduces problems with constipation, symptoms from hemorrhoids, and it does actually decrease the incidence of prolapse. So, but what's this got to do with the feet? Well, it's very hard to squat to go to the toilet in our Western culture. So our feet play a very important part in the correct defecation dynamics. And it's all about the correct sitting position on the toilet. So what you do is you lean forward with a straight back, elbows on knees and your feet on a stool. Why is it a poor choice of words? Oh, Peter, stool. Well, look, you know what? A lot of my patients, you know, I teach how to go to the toilet properly and always talking about the stool. And after the first visit, when they come back to me, the comments I get about that stool, you know, it's wonderful, you know, I take one in the car with me, I can't do it without it, it's just, you know, and I write all these down and I say to people, and it's true, I'm going to write a book about the stool, and it's going to be called The Stool for the Stool. And I think I have to get Darren Hinch to, you know, publicise it or, you know, promote it for me, because, you know, he's the man that promotes the All Brand and, you know, what is it, the All Brand Challenge. Okay, so here we go, the correct sitting position. So now we're going to talk about how to evacuate successfully, the best way to evacuate. Now, step 1, use the correct sitting position, and that is actually a really good picture of a lady on the toilet. See, she's mimicking the squatting position. See where her knees are, above her hips. She's leaning forward with a straight back. Now, I should have said there's a step before this, because, you know, you need to get the strong urge that you need to go to the toilet. There's no use going to the toilet like one of my patients said not long ago. I said, how do you know you need to go to the toilet? What is your, and I want everyone to think about this, what is your trigger that takes you to the toilet, right? Now, I hear a lot of comments. But this fellow said to me, he said, my head tells me. I said, no, wrong answer. He just goes because he thinks it's time, you know, I want to go to work, I'm going to go and try and go to the toilet because my head tells me I need to go. But it's not right. The answer is, and I'm sure you've all got it right, pressure and fullness in the back passage. Because that is, the rectum is full and it starts to come down into your back passage and you feel it there. So that's, if you go to the toilet when you get that feeling, you're going to have a good evacuation. So of course, before you go to sit on the toilet, wait for the strong urge. Use the correct sitting position. Step 2 is relax. And it's very hard for a lot of people to relax because there are a lot of people that get pain when they go to the toilet. You know, especially if their poo's really hard or if they've got other little problems with their bottom, which I'm going to discuss further in this talk. So try and relax. Take a few big deep breaths in through your nose and out through your open mouth, because it does relax all your muscles and your pelvic floor. Step 3, do not hold your breath like this man, because when you hold your breath, you're squeezing all your muscles. So don't take a big breath in, and you only use 2 muscles to go to the toilet, and that's your tummy muscle and your back passage, your anal muscle. So what you do with your tummy, you balloon your tummy out. You push your tummy out. Actually, I want you all to try this. And I want the first person, so all put your hands on your tummy, okay? And what I want you to do, don't do it yet, but I'm going to ask you to push your tummy out like a big balloon. So you widen your waist, pull your tummy out, and I want to ask, is anyone feeling any movement in their back passage? Okay, push your tummy out, push your tummy out. Does anyone feel any movement in their back passage? A few people are saying yes. Yeah, no, this lady's saying no, yes, relax. What that does, by pushing your tummy out, that opens the back passage and pushes it down. That's what it does. So the first thing is you push your tummy out, and the next thing you pump or you push your anal muscle, your back passage, a really long push, a long extended push. Step 4, draw up your back passage firmly to close it off. Close it firmly to finish. So just going over the golden rules, the fibre, 30 grams of fibre per day, fluids, 6 to 8 good fluid drinks per day. Your fitness, keep your body moving. And your feet, use your feet in the correct sitting position. Over there I've got some books and it talks about the sitting position in the books. Okay, so there are people that cannot follow a good bowel management plan, or even if they do, they still suffer with chronic constipation or slow transit constipation. So they can do the 4 Fs, but they still have problems. So what can we do about this? So as a clinical nurse consultant in bowel management, I'm not a big fan of laxatives. So laxatives are okay to use for short-term reasons, on very occasional reasons, short-term, to counteract short-term constipation medications. For hospital bedridden patients, short terms. For anal disease, short term for healing. For people with chronic disease and illness, all short term. And actually, there is no convincing evidence that the colon is permanently damaged by long-term use. So, you know, there's no research that shows that it's damaged, but I do have many, many patients who come to my clinic who have tried all the laxatives on the market, and after a while each of them become less effective. And so what happens, they need more and more. So the nature of the overuse of laxative is the bowel becomes progressively less responsive to all these agents, meaning that increasing doses are required. So people are going from that laxative to that laxative to that and they're getting griping pain and wind pain and, you know, from diarrhoea to constipation. I do see a lot of people like that. So laxatives have their place and only should be used, you know, in those short-term periods. So what we use for people with long-term constipation is Movicol. Does anyone know Movicol? Yeah. Okay, so Movicol, yes, few people do. What it is, it's what they call a Macrogol 3350 with electrolytes. It's what they call an isoosmotic. That's the type of medication it is. But what that actually means and how this Movicol works, and I have Movicol over there to show you, and I have brochures on Movicol. It's a very unique action. What it does, it delivers water to the bowel. It hydrates the faeces. It facilitates comfortable bowel movement. It does not act like a stimulant like other laxatives. It doesn't draw water from your your body into the bowel. It does not act like fermentation, like things like Metamucil, psyllium husk. That's how they act. They ferment and let off gas. So Movicol has a slightly salty taste. That's the original Movicol, but it's not unpleasant. It's like a fruit saline drink. You know, we all used to know that, didn't we, in the old days? The little fruit saline for a bit of energy. What I have noted with Movicol, that my patients need less and less. So if they start on a particular dose, you know, they're not like other laxatives where you need more and more, you need less and less. And some only need it for a short term. We put a lot of our patients at Royal Prince Albert Hospital that have big gynae surgery and abdominal surgery on Movicol for after the surgery, so they can have, you know, easy bowel movements. And I'm sure they do that here. So patients feel that they are more in control with Movicol because they can vary their dose. And it's an alternative to laxatives which really does work. And now, in the last year, it comes in chocolate flavour and flavour-free, and it's all on the PBS. So if you've got any, you know, a chronic constipation, you know, your doctor can write the script. There is another one called Osmolax, but it's relatively new. I haven't found it to be very good at all with patients, so I think it's going under. I know all the reps were fired because it wasn't going very good. So now we're going to talk about fecal incontinence, another really common problem. Obviously that person's used lots of toilet paper. So what is normal? So the ability to recognise the need to pass gas or open your bowels. The ability to defer gas or stool until socially acceptable time. So we usually can defer 10 or 15 minutes. The ability to recognise the difference between gas, liquid and formed stool. So what is fecal incontinence? So it's all the inability to do these things. So inability to control, you know, the gas or the stool from the anus. And it can even be skid marks on your underwear, or could be as big as a major loss of formed motion. And the inability to defer gas or stool, this is called urgency. Okay, it really does affect people's quality of life. Social isolation affects their work, their exercise, their travel, sex and intimate relationships, their personal cleanliness, self-esteem and confidence. I mean, you could say all that about urinary incontinence too, but I think it's a little bit harder to disguise fecal incontinence, so it seems to be a bigger problem. So what causes fecal incontinence? Look, many things too, like constipation, but the big one is childbirth injury involving the muscles or the nerves of the anal sphincter. This is the commonest cause. Injury to the anal sphincter following surgery around the anus, like an anal fissure, anal fistula, hemorrhoid, and I will be talking about those things in this talk. Injury to the anal sphincter from an accident or an infection, which could be an abscess. Chronic constipation with repeated straining may cause injury to the nerves of the anal sphincter, therefore people become fecal incontinent. Spinal cord injury, that's a big one, spinal cord injury. Miscellaneous causes, you know, those nerve-related problems, diabetes, multiple sclerosis and dementia. And it's really common. 1 to 7% of people suffer from fecal incontinence in our society. And at Prince Alfred we see 85% women and about 15% men who suffer fecal incontinence, and that is because of the childbirth injury. There was a study in the St George area. They did thousands and thousands of handouts of people asking them about fecal incontinence, but that actually came back. It was really interesting. It showed that 50% of women have it and 50% of men. which was quite interesting. But there was the question about, staining on your underwear. And a lot of men have staining on their underwear because they force out gas. Women don't do that. We're not allowed to do that. But with men, it's masculine, so forcing out gas is okay. But when they had to put it on paper, that their undies were stained. So how do you, fecal incontinence, how do you diagnose it? Well, it's obvious, isn't it? It's there, but, talking about the history, the rectal examination, colonoscopy to exclude diseases of the colon, anal physiology studies. So that is testing of the integrity of the anus. And of course the treatment all depends on the cause and the severity of the problem and the age and mobility of the patient, the health and motivation of the patient. So the nursing conservative management is the Biofeedback Program that we run at Royal Prince Alfred Hospital. And of course the first thing that we do is talk about the 4 Fs, education on the 4 Fs. Then we talk about other dietary measures, having the balanced diet, avoiding certain foods, because we all know that, certain foods that really can, make you run to the toilet. A lot of people tell me they can't have Chinese food, because they have Chinese, that really affects them. So increasing the intake of other foods or dietary measures, improving bowel emptying techniques. Because what I say to my patients, an empty vessel doesn't leak. So if you can empty out properly, it's not going to leak, half an hour later. So it's really important to use that correct, emptying out, with the stool and using, those steps to go to the toilet properly. So there's medications that can decrease the activity in the bowel and make the bowel, the stool firmer and making the bowel much easier to control. Because, if we all here today had diarrhea, it'd be really hard to control that. If I had it, it'd be really hard to control it. So what the point is runny poo, hard to control. So if anyone has a runny poo, they need to have a formed poo. It's much easier to control. You can add a fibre supplement, right, which is a bulking agent like Normafibre. And I'm going to talk about Normafibre here, and I've got a sample on the table over there. This is Normafibre. It's little white granules. And it's what they call an insoluble fibre. It's the only insoluble fibre on the market. And it's a natural source of fibre called Succulea, and it's from a Succulea urens tree in central India. And so this is the reasons why I give people Normafibre. And this is the little handout that I give people. And there's handouts on the table. What it does, it reduces the amount of gas production. So that's how it works. It doesn't ferment, it reduces the gas, which is really good. Because, the hardest problem to solve is people that are, can't control gas. That's quite hard. You can control stool and runny stool, but gas is hard. So we have to think of other measures. So it's fabulous. It reduces the amount of gas production. It bulks the motion up, right? So if people have nerve delay to their back passage, it's much better to have a bulky motion. It sticks all the motion together. I've had patients tell me, and multiple patients, it's like a Teflon-coated poo. So it just sort of slips out. That's good. It helps the motion come out all in one go and can reduce that fecal soiling because it soaks up all the fluid. So it tells you how to take it. It's granules that you swallow down with water. Now another thing we do in our biofeedback program is anal exercises to strengthen the anal sphincter. So what these exercises do, it involves in helping the patient to sense their anal muscle. So get a better feel of what their muscle can do. And you have squeezed and relaxed, encourage them to improve the response as it comes automatic. So we teach them, you know, a series of exercises. It's like pelvic floor exercises, but it's particularly anal, to the anal area. Now, another thing for fecal incontinence, anal irrigation. Very common in Europe, anal irrigation. Not so common in Australia, but more common than you think. And it's known as a colonic washout. There are centres around Sydney that actually you can go and pay for colonic washout. So another name is transanal irrigation or rectal irrigation. And what the patients can do, they can put just water, 500 mils, 1,000 mils of warm water into the lower bowel. So basically it just goes into the bowel and mixes with the motion, and then you're sitting on the toilet and it comes down into the toilet. And you hang the bag on a hook, but there's a bag, a hook, I'll show you a picture, and then you just slowly let the water go, you know, down into the tubing, into your back passage via a little cone. And people usually do this after they've been taught initially and practice it. They do it every second night. It takes about 20 minutes. It's actually a godsend to a lot of people that have really bad bowel issues. So who can use that? Anyone with constipation can use it, or fecal incontinence. It's the other story, you know, an empty vessel doesn't leak, or, you know, if you've got hard stool, it can help the hard stool come out. This is the irrigation kit. This bag is for people that have colostomies, but this section here with the cone is what goes into the back passage, and this gets filled with water. So irrigation, anal irrigation. There's another type of irrigation which is a step up, and this is for people usually with manual dexterity problems, people with spinal cord injury, people in wheelchairs, and a lot of those people have to have carers coming in doing their bowel management. You know, we're talking about, this is quite a degrading thing. So this is called the Peristine Anal Irrigation System. And who can use it? Well, as I said, people with constipation or fecal incontinence, and people that spend a long time on bowel management procedures, neurogenic bowel dysfunction, and where other alternative therapies have failed. And there are a group of people that can't use it. Anorectal malformations, people that have got really bad hemorrhoids, pregnant women, people that have active Crohn's disease or ulcerative colitis, which is like an ulceration in the bowel, and any big reason that they can't do it, irrigation. Children under 3 years of age can't do it. It's portable. It's easy to use, it's easy to teach. It does promote good bowel dynamics, defecation dynamics, no drugs, use only water, cost effective, provides independence, improves quality of life. It's actually got a balloon at the end of the catheter that you put the catheter in, and you blow the balloon up and it can stay in the anal canal. See, these people that use this system, say people like that are paraplegics, you know, they've really got no anal tone, and if they put water in it, just water would rush out. So you need like a little plug system there to keep the water in. And it's got a unique pressurised bag that you can put it on the ground. So, and you just pump the water into the bowel. See, people that are in a wheelchair can't hang a bag right up there for gravity feeding. So this is a bit of a picture of what it looks like. That's the catheter and that's the balloon that you blow up. So how does it work? It works like the other irrigation. You sit on the toilet, they put in the water, and when it mixes into the lower bowel, then it comes out in the toilet. It takes about 20 to 30 minutes. And it's so successful that people do this every second day. Now, the surgical management of fecal incontinence. So So if the sphincter has been injured, leading to a gap in the sphincter muscle, usually as a result of childbirth, a repair is often possible through the skin in front of the anus. And up to 80 or 90% of patients have good response. Now, if there's some ugly pictures here, I'll go quickly, all right? Oh, it's not ugly. Okay, so that basically what it looks like. You know, they've had a baby, they've had a break in the sphincter. That's where the operation started, and they overlap the sphincter. This is really good. This is really good. You know, a lot of women having babies, you know, they have big tears and then they need their anal sphincter repaired. But there are a lot of women out there that have had a tear and they've suffered with bowel issues for 30 or 40 years. And they eventually have the courage to do something about it. And, you know, we find out their anal sphincter's broken from the childbirth. And that baby's 35. So we can do the repair. So let me just go quickly. It's a bit ugly. Okay, this is an ultrasound picture of a break in the anal sphincter. You can see it there. This is a picture of the overlapping sphincter repair. You can see how it comes around there and then it comes over there. Now the newest thing on the market is sacral nerve stimulation, and this was developed in the 1980s, first of course in Europe in 94, then came to Australia in 2005. And it can improve the quality of life and by eliminating and reducing the symptoms suffered by people with fecal incontinence. The sacral nerve stimulation helps to restore the normal nerve activity, right, to the anal area. So the patients can defecate normally without fecal incontinence. Look, it's not really understood how it works. There's lots of research being done about this, and we hope that we can find out. But they are admitting they don't know how it works. So what it is, basically it's like a pacemaker. You know how you have like a pacemaker and it's implanted under the skin? And what it does, it's got a little wire that goes to the heart and it makes the heart pace properly. And that's what this does, this sacral nerve stimulation. It's a little implant at the top of the buttocks. It's got a little wire that goes down towards the anal nerves and it stimulates those nerves. It's not really an operation, it's a procedure, and more and more people are having this done, and it's proved really excellent. You know, in the 19 years I've been running this clinic, you know, the developments have been wonderful with people with bowel dysfunction. So, you know, I do a lot of talking to people about bowel dysfunction. I do a lot of talking to midwives about bowel dysfunction, and always say, look, please tell the patients, you know, there is something can be done. Don't suffer at home with a bowel problem. You know, see someone about it, because there's a lot of research, and we do a lot of research in our centre to help people with bowel dysfunction. And this is one of the things, the sacral nerve stimulation, that's come out of all that research. So who's eligible for the sacral nerve stimulation? You've got to have had all the testing, and been to the doctor. You've got to have some conservative management, because sometimes, you know, you can, help people with you can help people with fecal incontinence, and so they don't have to go on to sacral nerve stimulation. So of course at our hospital, you know, they come through our program, and I would say 80% of people we can fix them through our program, and probably 20% are offered the sacral nerve stimulation. This is where it's implanted, the top of the buttocks, and that's what the little stimulator looks like. It's like a pacemaker. The next thing is an anal plug. It's like an anal tampon made by Coloplast, and this works really well too. This can go in and can stay in for 24 hours. A lot of people who play golf like to use this because they want to be safe. So an anal plug, so it really does exist. Surgical management. Okay, so it can be a stoma. Here's a fellow that's really happy to have his stoma. Look, the stoma formation may be needed in patients with severe problems. It's often considered the last and least most popular option, yet it does return the dignity and control to an often chaotic life. Now this fella, he has Crohn's disease, and he goes to the toilet, 20, 30 times a day. Imagine what his life would be like. So, he's really happy to have his picture taken, with the stoma. Look, there's new developments, there's new research. There's talk of this tibial nerve stimulation and suggestion from China for reflexology. What next? We don't know. There's going to be something. Okay, next thing I'm going to talk about is obstructive defecation. Very common problem. Often mixed up with constipation. So it's described as inability to evacuate contents from the rectum. And there's a lot of things it's called as well. Paradoxical puborectalis contraction, outlet obstruction, anismus, pelvic floor dyssynergia, non-relaxing puborectalis syndrome, spastic pelvic floor syndrome, dyssynergia. But basically what it is, this is what it is. This is what people tell me. They say, it's there, or is it? I want to get it out. I try, but I can't. It feels like it gets stuck. There is something stopping it. Sometimes I get some out, I never feel empty or completed. So people tell me it's like I can get it to the back passage, but I can't get it out. There's an obstruction there. And you know what? There's a lot of people out there, a lot of medical people don't understand this, but it's a real problem. So what causes it? Anismus, or pelvic floor dyssynergia. So that's tightness of the anal canal. Incomplete prolapse. This is internal, or it could be internal or therefore not visible from outside the anus. So a mucosal prolapse, so the lining coming down. This involves only the inner lining of the rectum. Complete prolapse, protrusion of the full thickness of the rectum coming out the back passage. Hemorrhoids, constipation, rectocele. I'm going to talk about rectocele in a minute. So what you do first with these people is conservative management. The fibre, the fluids, the fitness, teaching, sufferers good defecation dynamics. Teach them only to open their bowels when they get the strong urge, not when their head tells them, like that fellow. Because, people that can't get out, they find they're going back and forward to the toilet, trying. It's a horrible feeling that you can't go properly. So we tell them to do not strain or force. Use a bulking agent to make it soft and bulky and Teflon coated. And explaining about the puborectalis, because people that strain, they find that this muscle gets even tighter. So that's where the toothpaste story comes in, tight. There's surgical treatment for obstructive defecation. If it's caused by prolapse, might need a surgical repair, or hemorrhoids, might need a surgical repair. I mentioned the word rectocele. So a rectocele can be a major problem with obstructive defecation. Now I want to describe what a rectocele is. Men don't get this. This is a women's thing. So what it is, it's a forward pouching of the rectum towards the vagina. It's a very common problem, and it's also known as a hernia or a pocket or a prolapse. So it's a weakness in the lower rectal wall. 95% of women that have had a vaginal delivery have some type of rectocele. Some of them might not even give them symptoms, but I see a lot of really bad people with rectocele. So it's women that have had a baby by vaginal delivery. 95% of women who've had vaginal delivery has some form of rectocele. Women who have strained repeatedly because of heavy lifting or constipation. Look, I have heard it reported in men, but it's very rare, very rare. This is a picture of it. I'm not going to go on about that. It's a bulging within the vagina area. And the symptoms are a sensation of pressure within the pelvis, the feeling that something is falling down or falling out within the pelvis. Symptoms are worsened by standing up and eased by lying down. Lower abdominal pain, lower back pain, a bulging mass felt in the vagina, vaginal bleeding and not related to menstruation. Look, it goes on and on. You know, it's painful, impossible vaginal intercourse. You know, and that might be some women's excuse for not wanting intercourse because they have a problem they don't even want to discuss with their partner. Constipation, problems with passing a bowel motion because the stool can get caught in the bulge. Rocking on the toilet to try and get the motion out. Using pressure, digital or around the anus, assisting the bowel moving. Feeling that the bowel movement isn't completely emptied. And fecal incontinence. You can get fecal incontinence because if you can't empty out properly, you're going to get leakage. And what they call post-defecation soiling. You've been to the toilet, you think you've done it all, but you know there's a little bit in that rectocele that's going to come out. So conservative management, behavioural therapy. You know, a lot of people with bowel dysfunction get very devastated by their bowel dysfunction, and it can go hand in hand with emotional upsets. So Janet and I, who I work with, we found where we can be everything to our patients. You know, their friend, their daughter, their mother, you know, their social worker, their psychiatrist, you know, their teacher, their confidant, everything. And that can really help people discuss and help their bowel function. So the treatment is our biofeedback therapy, the 4 Fs, fibre supplements, making the stool normal, teaching the good bowel function, how to go to using the stool. And some women have to use a pessary. Now this is implemented by the gynaecologist. So it's a ring to keep the prolapse up. Perineal pressure and perineal support is common. Women have to use support to help the motion come out. I won't go on about this because there's a lot of men here, but you know, I've left my cards there. So if anyone wants to talk to me about it or feel they have a problem with anything here, any of you, you know, you can see me. But obviously you have to go through one of our doctors first. If I said to anyone come and see me, we couldn't exist. It'd be just, there's too many people. Last week Janet and I saw 20 new patients between us, and we both work 4 days a week, and that was probably about 60 old patients, but 20 new patients, an hour and a half each person. So, you know, it's good because we're really busy and we do need more staff, but it's, you know, we're helping people. And doing, you know, talks like this, I do a lot of talks, you know, it really can help people. So I'm going to talk about some benign anorectal conditions that result in a bowel dysfunction. Hemorrhoids, pruritus ani and anal fissure. So let's talk about hemorrhoids. This is a really common thing. I see a lot of people in our clinic with hemorrhoids. And the reason is our doctors don't want to operate first line treatment with hemorrhoids because hemorrhoid is a functional problem, right? You don't get them because you sat on the cold steps or because your father has them. It's a functional problem. It's something you're doing with your function that causes hemorrhoids. So to be kind to our patients, if they can have a one-off lesson about how to have good bowel function, it can really help them avoid having hemorrhoids again. So they go back to the doctor, you know, if the hemorrhoids have settled down, you know, they won't go and do any operation. So what they're described as, they're varicose veins. These enlarged veins can be internal, so they can be up high in the anal canal, or they can be external, which is just on the outside of the anal canal. Usually not painful, but when inflamed or thrombosed can be painful. A thrombosed hemorrhoid, that means it's like it's clotted and occluded, can be clotted, and the blockage of blood through the vein. So thrombose is quite painful. So what happens? Increased pressure within the veins of the rectum causing congestion of the hemorrhoids in the rectum and anus. So that's how you get the causes. And pregnancy, childbirth, is very common after all that hard labour women have to go through. Weightlifting, long periods spent on the toilet. So, you know, if you think you've had hemorrhoids, if you think you have or you have had them, don't spend a lot of time on the toilet, because it's all that pressure going down and the blood flow going down can increase hemorrhoids. Straining or forcing to pass a motion. These are all the causes. So the symptoms are bleeding after a bowel motion, and this may be on the toilet paper or in the bowl. It's very bright blood, and when it drips into the toilet bowl, it just spreads, and it seems like seems a lot. So what you've got is a prolapsing little perianal lump, a little lump around the bottom. Pain is a complication of hemorrhoids if they are strangulated, engorged, with blood or ulcerated. Itching, pruritus ani, is caused by a mucus discharge. So you can get itching because the hemorrhoids produce mucus. That's the reason the hemorrhoids are there. Hemorrhoidal cushions are there. They produce mucus to lubricate the motion. And if we're trying really hard to go to the toilet, those hemorrhoids start getting bigger and swollen, and they produce more mucus. I get a lot of patients coming to me with the itch, and I'm going to talk about that in a minute. And the itch is usually from internal hemorrhoids. You know, they've been sitting on the toilet too long. They haven't been answering the right call to go to the toilet. So the treatment for hemorrhoids is the conservative management. Teach them how to go to the toilet properly. Teach them about fibre fluids and fitness. Teach them about the stool. Teach them about going, you know, when you get the strong urge. Don't spend more than about a minute on the toilet. Sitz baths, that's a salty bath to ease the discomfort. Use wipes, not toilet paper, or topical anaesthetic ointments, you know, Anusol. You know, you can buy them all at the chemist. Now, the procedures for treatment of hemorrhoids: injection with phenol, rubber banding to obstruct the blood supply and cause separation, or a hemorrhoidectomy or a stapled hemorrhoidectomy. So they're the procedures. So, you know, the common you hear, it's injection. You know, I've had my hemorrhoids injected, or I've had them banded, or I've had them cut off. Very painful. Now we're going to talk about pruritus ani, itchy anal area. Very common and an awful thing to have, because, you know, you don't want to itch yourself in public, because it's not a really good look, is it? No. So what causes it? Seepage of faeces or moisture. So hair near the anus may aggravate the problem. Skin becomes irritated, causing itchiness and the urge to scratch, and this leads to skin damage, and then that leads to more irritation. Then this persistent cycle starts. You know, it's itchy, you can't bear it, you itch it, you damage the skin, it becomes more itchy, it becomes sore, and it just goes around and around and around. So people who to get this, you know, it could be allergies. I mean, diabetes can all be the causes. Inflammatory bowel disease may cause this. In children, it could be threadworms, or hemorrhoids associated with mucus discharge can be associated. So the treatments, you've got to treat the cause. Find out why they have the itch. Keep the skin clean and dry. Good anal hygiene. Ointment to reduce the itch and heal the skin and act as a barrier. Use cornstarch as a powder around the bottom. Or there's a few on the market. Prantel powder is one that I do say to a lot of people. You know, try cornstarch because it sort of soaks up the fluid. Prantel powder. So then to tell people about the golden rules of good anal hygiene. So only use the softest toilet paper. Do not over clean or over rub, because this happens a lot. Wash with water and use a dabbing action. Do not use soaps or antiseptics. Don't use Dettol or methylated spirits. This happens. It happens. It happens. Dry well. You can use a hairdryer on, very, very low heat. I know when I had my babies, we used to use hairdryers. I don't know whether anyone here did, but you have the baby, and there's a few people nodding. Wear cotton underwear. Don't overuse cortisone, steroid ointment, because what it can do is really thin the skin. You can use it for a week or so, but don't use that continuously. Now we're going to talk about anal fissure. This is another really common thing, very common, and it's a crack or split, usually located in the posterior, so the bottom part of the anal canal, which is the part towards the back, not at the front of your anus. The crack or the split fails to heal and becomes a painful ulcer associated with spasm of the anal fissure. So the crack it goes quite deep into the muscle and it makes it spasm. It's a very common problem, and most fissures heal in a few days, but it can become a chronic problem. So what it is, an anal fissure results from stretching of the anal muscle caused by constipation or forcibly straining when opening the bowels. Now, it's really painful, really very, very painful. I can tell if patients come in to see me, if they're in so much pain, I think to myself, they've got an anal fissure. It's really bad. It's really bad. But that's the chronic ones. So what are the symptoms? Of course, pain on opening the bowels, and that is from the spasm of the anal sphincter. Bright red blood on the toilet paper or in the bowl. Now, as opposed to hemorrhoids, because we're going to see blood because of hemorrhoids, but we're not going to see pain so much. So if you have pain and blood, we're thinking of an anal fissure. So there's a little tear in the skin, and it's from secondary to constipation when defecation is delayed for painful movement. Now that means is, if you've got pain every time you go to the toilet, and you know that like for 3 hours after you go to the toilet you're going to have terrible pain, or even half an hour, you tend not to go to the toilet. And if you're putting going to the toilet off, you are going to become constipated. So, you're in this vicious cycle again. Treatment. There is treatment. Decrease the spasm caused by the fissure, which allows the crack to heal. But first we do the 4 F's, teaching them how to go to the toilet properly, making sure they're not constipated. Now we have ointments that relax the anal fissure and enhance healing, and that's called rectogesic. And that's just put on just the anal area where the crack is. Botox injection to relax the crack and enhance the blood flow. So the first thing is changing their diet. The second thing is you can try the ointments. If that doesn't work, they can have a Botox injection. We do all this in our clinic. And the next one, so a large portion get fixed by that. Then if people have this chronic anal fissure, and it may require a surgical option, and it's called a sphincterotomy, and it's a real conservative cut into that crack which releases the spasm muscle. And there are complications, mild incontinence. That is reported. It's never happened to any of our patients, but it is reported. We don't like to do this little incision, little procedure with women, because women, you know, are already, after having babies, they have potential problems anyway. So men, we would do that, but there's all those measures beforehand. That is the end of my talk. Thank you. That wasn't 45 minutes, that was about an hour. So if anyone's got any questions, not problems, any questions, or anyone over there would like to take anything that's on the table, please do so.
Well done, Jenny. You are one lady with intestinal fortitude, I would say.
Thank you, thank you.
And I thought I was coming from behind, but I'm fine now on this subject.
I was put on medication, iron tablets. As a consequence, I got severe constipation. I saw the doctor and he put me on psyllium husk or something like that. That is helping, but I've got to make sure I take the right dose. If you don't take enough, you're still constipated. If you take too much, so you've got to try and work out.
You've got to get the balance, haven't you? Yeah. Psyllium husks is good. Look, it's soluble fibre. It's the same as it's Metamucil is psyllium husks as well. It's a good bulking agent. Much better, psyllium husks are much better for men than women. We find a lot of women get a lot of gas, a lot of wind, a lot of bloating with psyllium. But, you know, for men it seems to work really well. Very good. That was a good suggestion.
That'd be better than the medical, you know, buy those tablets, I think.
Much better. Look, you know, it's much better if you have the constipation is to have something like your food and diet rather than going to get your pills.
Thanks very much.
Very good.
Thank you. Usual, most interesting talk. Just following on from the first question, I think you started to say about when's the best time to take the psyllium and about how much you recommend?
Well, it all depends. You know, you can buy the psyllium in a big bag. Do you use yours in a big bag, a psyllium, their psyllium? You know, how much did your doctor tell you to take? He didn't. You just, look, you can just put, you know, like a big tablespoon.
The full dessert spoon, I always tell them.
Yeah, well, a full dessert spoon. You know, it's just what suits you, you know, and this gentleman said he's got to sort of get the right dose, and, you know, every person's different. So, you know, you start on maybe a tablespoon, see how that goes. But the important thing with something like psyllium, you need to drink your water. 6 to 8 glasses of fluids, you know, the good fluids per day. If you don't, it doesn't work so well.
I was just wondering about the difference between Normafibre and the psyllium husks.
Okay, yeah, that's a good question. Now, Normafibre is what they call an insoluble fibre, and the psyllium or Metamucil is a soluble fibre, and they work differently. So the Metamucil or the psyllium husk, how it works, it ferments and lets off gas. So that's why generally people have a lot more gas, you know, and it's more suitable for men. And the Normafibre, it reduces the amount of gas. It's really good, much better for women. So I put a lot of my patients on Normafibre, and a lot of men do take it as well. There's the information sheet over there on it. Yep.
So you have to drink a lot of water with that too?
Well,
you have to drink water with that as well?
But yeah, it's not so much as the Metamucil, but, you know, to have good bowel function, you need 6 to 8. I mean, people that get simple constipation, it could be that, you know, yesterday, you know, I was, say, talking about myself, say I was shopping all day and so busy I didn't have any drinks of water. So, you know, with people, if that happens to you, and it can happen, the next day you'll find things aren't so nice in the toilet area. Now, I have a lot of people nodding here, so, you know, it can be as simple as that. You know, the fluids are really important.
Ken?
What about having 10 prunes with your cereal of a morning?
10 prunes with your cereal in the morning is absolutely fabulous.
As opposed to 8.5.
Yes, no, that is
Marvellous.
fabulous.
Thank
Look,
you for that information.
That is fabulous
Because that's what I have every morning.
Very good, because see what you're doing there, you know, there might be other people out there that might think, oh, you know, I'm going to take a laxative, or I'm going to have some new lax, or I'm going to have some Coloxal, or I'm going to have some Senna. Why not? Do it yourself. Have 10 prunes, figs, dates, all those really good things that get you going.
Ken often upstages me. That's another one. I take 3. I'll have to up it.
See, prunes are a very, very high fibre fruit. So, you know, that's why prunes work really well for people.
Okay, one last question.
Have you any comment on Coloxal and Senna?
Yes, I do have a comment. I'm not fond of it. Definitely not fond of it. Coloxal and Senna is one of those laxatives, you know, that, you know, it forces the bowel to work. It's a stimulant. The Senna is a stimulant, so it forces the bowel to work. And it does make the bowel lazy, you know, it does make the bowel lazy, because it doesn't have to work because it's being forced to work. No, I don't like it. I would rather have 10 prunes.
There you go again, Ken. Okay, we better wrap it up. Thank you to everyone. I think because of Jenny's presentation being so comprehensive and effective, she's answered a lot of the questions before you've got a chance to ask them. So if I can say on your behalf, another big thank you to Jenny for turning up. It's always great to have her, and she's always in demand. I recommend that you get in touch with her on anything like this, because she is an expert and she obviously loves her work, and we love to see her.
My pleasure.
So thank you very much.
Anytime.
Help me thank her.
Yeah. Thank you.